Hello and welcome to the Parkinson's Foundation Cognition Talk Series. Today's presentation is Thinking Changes in Parkinson's. I'm Erin McGee, a program manager of the Parkinson's Foundation. Some people with Parkinson's disease experience cognitive challenges, and the Parkinson's Foundation Cognition Talk Series focuses on those cognition concerns. Parkinson's disease is complex and can take multiple professionals to work collaboratively to deliver your optimal care plan. All the pre-recorded talks in the series are presented by one of our care team professionals who will help you become more familiar with how each can add their perspective and recommendation for optimal living with Parkinson's. Today's focus is the role of the movement disorder specialist, neurologist, plays in the Parkinson's care team. Before we begin, we want to welcome those who are joining us for the first time and take a moment to share the mission of the Parkinson's Foundation. Every day and in everything we do, we are working to make life better for people with Parkinson's. To achieve our mission, we pursue three goals: improve care for everyone with Parkinson's, advance research toward a cure, and empower and educate our global community. Today's program is a great example of one of the many things we are doing to help us meet these goals. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day Foundation, for your support. And now I'm pleased to introduce our speaker. Jennifer Goldman is Section Chief for Parkinson's disease and movement disorders at the Shirley Ryan AbilityLab and Professor of Physical Medicine and Rehabilitation and Neurology at Northwestern University Feinberg School of Medicine. Dr. Goldman is a clinical researcher who has been a pioneer in the cognitive and behavioral aspects of Parkinson's and movement disorders, and a long-standing champion and leader in interdisciplinary care. Dr. Goldman has been funded by the National Institutes of Health, Michael J. Fox Foundation, and Parkinson's Foundation, among others, and has published over 85 research articles and book chapters. We are thrilled to have her join us live today after her pre-recorded presentation. So be sure to submit questions during her presentation and afterwards by typing in the Q&A box. So let's go ahead and settle in to watch her presentation.
Parkinson's disease and cognitive changes. Hi, my name is Dr. Jennifer Goldman, and I'm a movement disorder neurologist who has focused much of my career on understanding and treating the cognitive and behavioral symptoms that can occur with Parkinson's. Today, we're going to talk about cognitive changes in Parkinson's. We'll talk a little bit about their clinical features, how we assess them, why they may occur, and some management strategies for when they occur. A few immediate takeaway messages that I'd like to highlight here. First and foremost is, even though we're talking about cognitive changes in Parkinson's today, not everyone with Parkinson's will experience cognitive symptoms. We know that people with Parkinson's are very individual in their journey with Parkinson's. So not everyone experiences cognitive or even behavioral symptoms. However, it is important to talk about them, although these topics can be difficult to talk about or hear about. But knowledge is power, and accurate definitions and information are important. There are treatments and management strategies and help for people who are experiencing cognitive changes. The teamwork and research and clinical care along with knowledge and empowerment, can make all the difference. So first we'll start off and talk a little bit about what is cognition. Cognition actually comes from the Latin root cognoscere, which means to know. So cognition is our mental processes of how we perceive the world and how we interact with the world and acquire knowledge and understand things through our thoughts, our experiences, and our senses. It's often equated that memory and cognition are the same. However, cognition does not equal memory. There are many different facets to cognition, and they include many different cognitive processes. Some of these, to highlight a few, include different cognitive domains, and these can be explained by putting together similar cognitive features into one area, or one domain, or one bucket, so to speak. These can include attention, learning and memory, working memory, which we'll talk about in a little bit, comprehension, language, judgment and problem solving, reasoning, and visual spatial function. Often in Parkinson's, we collapse some of these domains to think about the top 5. And those include attention, such as paying attention or concentrating, working memory that I mentioned before, which is the ability of someone to hold something in their head while their mind and brain is working on something else. So such as holding a phone number or an address in your head while we talked about something different. Executive function, and this is a key area in Parkinson's. Executive functions encompass a wide variety of cognitive symptoms, including our abilities to plan, organize, stop and start activities, and have mental flexibility. Memory is another area we'll talk about in Parkinson's. Memory can include what we call declarative or episodic memory. So memory for facts, knowledge, things about the world around us. There also can be procedural memory, such as how to. So how do we know how to ride a bicycle or things like that? Language, which is less commonly affected in Parkinson's, but most frequently can present as difficulty with word finding. So having that word on the tip of one's tongue. Visual spatial function, we know, can be also affected in Parkinson's. And this includes navigating the world around us, from knowing how to get from point A to point B when driving or ambulating, or knowing where something is in space and in our environment. It also can include our sense of judgment about distances. So all these factors go into cognition. So what do we hear from people who might be experiencing some of these cognitive changes? Well, oftentimes people will say, oh, my memory's bad. But as I said before, there's more to cognition than just memory. And in fact, sometimes it's not even their memory that's the problem area. It could be having difficulty with concentrating or paying attention, such that the information is not actually getting into the brain to be remembered. People can have executive function challenges, as I mentioned before, that can show up as having a hard time with planning or organizing or keeping track of things. This may be apparent in like paying the bills or driving, difficulty with multitasking, or following a recipe, just to name some examples. We talked a little bit about memory for facts and details, and sometimes we hear from a person or from their spouse or care partner that they may have forgotten details about an event that happened a short time ago, or something they may have just been told. Long-term memory tends to be more spared, so thinking about events where someone went to high school or when they got married or where they grew up. So we tend to see more effect in short-term memory. Language, as we mentioned before, we see people talk about, I just can't find the right word, or I know what I want to say, but it just isn't coming quite out. And visual spatial function, also, as we talked about, can be present if someone's having a hard time navigating around, maybe making wrong turns when they're driving or getting lost in an unfamiliar environment. And this can have implications for driving. Interestingly, when people talk about memory challenges, people with Parkinson's are known to respond better to what we call recognition or cues. So one tip for someone living with Parkinson's or their care partners and families is to give choices or to give prompts or cues, because often that helps to jog one's memory, so to speak, and people can fill in those blanks. So these cognitive areas that I mentioned before reflect different processes going on in the brain. They involve a number of different lobes of the brain and areas of the brain that we know can be affected in Parkinson's, including the basal ganglia, the frontal lobes or the prefrontal cortex, which is highly involved in attention and executive function, parts of the temporal lobe, which are involved in memory and language, and areas such as the parietal, occipital, or temporal lobe that can be involved in visual, spatial, and visual perceptual processing. So just a little neuroanatomy lesson as we think about the brain and how areas of the brain are reflected in human behavior. So why do we think these cognitive changes can occur in Parkinson's? Well, we know there's actually a neurobiological basis for them. They can include changes in some of the brain chemicals like dopamine. Dopamine can be involved in attention, working memory, and in executive processes that we mentioned before. Acetylcholine can be involved in attention, working in memory, as well as gait and balance. We also know that the Lewy body, that pathological hallmark of Parkinson's that we see under a microscope as a protein aggregate or clump, if you will, can be deposited in different areas of the brain. Some of these brain areas are those that are involved in thinking and memory and overall cognition. And they may be responsible for some of the clinical changes that we see in cognition. There can also be changes in other brain proteins that can be measured mainly on a research basis through fluids such as the cerebrospinal fluid, which bathes the brain and the spinal cord. Some of these markers, such as amyloid beta and tau, are also studied in Alzheimer's disease and may suggest for some people that there can also be multiple reasons or multiple pathologies at play. We'll talk more about some of that later in this session. So how common are cognitive changes in Parkinson's? That's a question we often get asked. And we base this on studies that have been done in the literature over many years. We know that their frequencies can vary depending on the population studied, how the study was conducted, what assessments were used, and so forth. But some of the statistics that have been put forth include that mild cognitive impairment, and we'll talk about how this is defined in a moment, may occur in about a quarter or up to 50% of people living with Parkinson's. These mild cognitive changes can be present even at the time of diagnosis or early in the course of Parkinson's. And there may be different reasons behind these mild changes that we see early in Parkinson's compared to some of the cognitive changes we see later in Parkinson's. About 40% of people may develop what we call a dementia. And again, I'll talk about definitions in a moment. And this may increase with more advanced Parkinson's. Again, going back to my very first point to make is that not every person with Parkinson's will experience cognitive changes or dementia. So please keep that in mind as we talk further about this. So let's talk a little bit about how we define cognitive changes in Parkinson's. This is a broad spectrum, and as I mentioned before, includes a number of different clinical symptoms, but how do we put them together? So perhaps at its most mildest of forms is something we might consider bradykapnia, which means slow thinking. This is much like our concept of bradykinesia that is well known in Parkinson's for movement, meaning slow movement, or the things we do when we assess a person with Parkinson's, like have them tap their fingers or wave their hands or stomp their feet. People can have mild cognitive impairment, which has now been defined as a construct in our field. And in those situations, people can have mild changes in one or more areas of their thinking or cognition, but these changes are mild. They are not affecting someone's ability to do their day-to-day tasks, whether at home or at work or in other environments. Some people can develop dementia. And dementia, by definition, is a gradual process. It doesn't happen overnight, but over years can develop. In dementia, people have more than one area of cognition affected. Commonly, executive function and visual spatial function and attention in Parkinson's, as well as memory and other areas. So there's more than one area that's impacted. In addition, in dementia, people are experiencing cognitive changes that are significant enough to impact their day-to-day life, such as having an effect on their ability to do tasks at home, things at work, more advanced tasks such as paying their bills or cooking or driving, as well as for some everyday tasks like bathing and getting dressed and what we call activities, basic activities of daily living. We know that cognitive changes impact people with Parkinson's in many different ways, and that there can be different rates of progression. Mild cognitive impairment in Parkinson's has now been defined as a construct, mainly so we can talk the same language as clinicians and researchers and have uniform criteria when we look at clinical research trials for medicines to treat mild cognitive impairment, sometimes known as MCI, or ultimately to slow it down or stop it in its tracks entirely. Dementia in Parkinson's is different from dementia and Alzheimer's. And I think that's an important distinction to note. So dementia in Parkinson's occurs within the context of diagnosed Parkinson's, but there can be some different features. It is a bit more common in Parkinson's to have certain cognitive domains affected, tending to favor attention, working memory, executive function, and visual spatial challenges. In Alzheimer's, memory deficits are central. People with Alzheimer's can also have predominantly memory or language affected. Note that there can also be an overlap. And as I said before, it is quite possible that people can have what we call mixed pathologies, meaning they can also have a little bit of changes in their brain that reflect underlying Alzheimer's pathology as they get older. People can have other mixed pathologies related to cerebrovascular disease, such as with long-standing high blood pressure, diabetes, or high cholesterol. So we know that Parkinson's symptoms encompass a wide variety of motor symptoms as well as non-motor features. And we know that people with Parkinson's may experience these symptoms all related to one another. For example, within cognitive impairment or dementia, people may be noted to have greater sleepiness during the daytime. They may have fatigue or apathy. And some of these can go along with cognitive changes and play a role with them either in being sort of a chicken and egg phenomenon, which one caused which, or which one led to which symptom appearing. Some people with cognitive changes may also experience hallucinations, or what we call psychosis in Parkinson's. In addition, there are mood changes such as depression or anxiety, which often can be heightened and have a relationship with cognition. So why is this? Well, because many of the same brain chemicals and brain changes in Parkinson's that are responsible for depression or anxiety or apathy may also be the same ones that are involved in cognition. So when we think about someone with Parkinson's and are evaluating them in the clinic, we need to put all of this together. So we need to think about cognition and how it relates to these motor and non-motor symptoms. So how do we assess cognition in Parkinson's? Well, in this series, you'll also hear from some of my other team members on the interdisciplinary care team on ways that we assess cognition, and also ways that we can work together as a team to evaluate someone's cognition and come up with strategies for managing it. So first and foremost is to ask and to understand, is someone having challenges in these areas, and do they represent a change from where they were previously? It's important to have a baseline assessment of cognition, much like we do for motor features. So we know what someone's tremor or slowness or rigidity and gait look like from the very beginning of their Parkinson's. So it's important for us to do the same type of assessments for cognition, to understand where someone is at the very beginning. Similarly, it's important to follow people over time with repeated assessments of their cognition to see if things are stable or if they have changed. Cognitive assessments can take many different sizes and shapes and forms. They can be quite simple, such as screening questions, what we call bedside tests, short assessments that we can do in the clinic. Assessments can also be more formal and comprehensive, such as neuropsychological testing batteries that can take several hours to complete and can really go into detail in all those different cognitive domains and areas I mentioned before. It's also important to understand how cognitive changes may affect someone's function. What does this mean on a day-to-day basis? What does this mean at home, if someone's working, or in terms of their safety, such as driving? This is where we can work hand in hand as a team. Many people on the team can assess cognition. So not only the neurologist or movement disorder neurologist like myself, but also our neuropsychologist, our occupational therapists, our speech language pathologists, and more. Sometimes our physical therapists also work on what we call dual task assessments, in which case they're looking at cognition and movement all at the same time. So there are a number of factors that can affect cognition, and these are important to exclude in case they may be contributing to someone's cognitive changes. These can range from hearing loss or vision loss, which can affect how we perceive the world and take in knowledge about it. People may have had underlying strokes, seizures, or head trauma, or other neurologic conditions that can contribute to cognitive changes. People can have medications that they're taking for other reasons that can sometimes cause confusion or cognitive changes. These tend to be medicines that what we call get into the brain or affect the central nervous system and can cloud one's cognition. Some of these medicines are often used to treat pain or sometimes bladder dysfunction that can be common in Parkinson's. So it's always important to have a list or record of your medicine to share with your physician at every appointment. So let's talk a little bit about management of cognitive changes in Parkinson's. So we already talked about some of the objective assessments to have at baseline and serial evaluations over time. We talked a little bit about that it's important to exclude other causes or reasons why someone may develop cognitive changes. This is especially true if cognitive symptoms occur acutely. Most times cognitive changes are gradual. So if something's happened overnight or over a very short period of time, we as physicians and the healthcare team need to look for other causes. Does someone have an infection, which is often our number one cause for acute confusion, such as urinary tract infection, or is there something else at play? Could they have hit their head and had head trauma, an underlying stroke, or a new medicine that was started by another person on the healthcare team? It's important to review people's medicines, as I mentioned before, and not only their Parkinson's medicines, but medicines and supplements and other therapies they may take for reasons outside of their Parkinson's. In managing cognitive changes in Parkinson's, it's really critical to address some very difficult topics. Sometimes these are sticky topics because they can affect someone's independence. And we really do want to maximize people's independence and enhance their quality of life, but we want to do it safely. And so some of these sticky topics can include driving, working, and other day-to-day activities such as paying the bills, maintaining accounts, and other things that can represent independence to someone. You may hear from some of my colleagues about how we assess driving and other tasks to understand, is someone okay to do these things, or do we need to make some changes? When there are cognitive changes, whether they may be mild, moderate, or severe, there's always an adjustment. These are new symptoms perhaps, and they can affect someone's day-to-day function. They can affect someone's relationships as well. And that's why having a team approach, as you'll hear from some of my other colleagues as well, is very important. So we want to be able to help not only the person with Parkinson's, but also their care partner and family in managing cognitive changes, or really any changes for that matter in their Parkinson's. So when we think about treating cognitive changes from a medical standpoint, there are a few items to note. So right now to date, only one medication is approved by the FDA in the United States for the treatment of Parkinson's disease dementia, and that is rivastigmine. This medicine works on some of those brain chemicals that we talked about before. As a cholinesterase inhibitor, it helps in the acetylcholine cholinergic system. Other medications that have been approved for their use in Alzheimer's also include cholinesterase inhibitors and another one called memantine. These have been considered off-label for treating Parkinson's disease dementia, but are not approved by the FDA for these indications. Parkinson's disease mild cognitive impairment is another area under study for improving our treatments from the medical or pharmacologic perspective. Several medicines have been tried to treat Parkinson's disease mild cognitive impairment in some research studies. These have included medicines such as rivastigmine, rasagiline, and atomoxetine, all which work differently. Unfortunately, those trials, which tended to be small, did not show a positive impact of the medicines on the cognitive measures that were studied. Now, there may be many questions about these trials and what are the best measures, the best time to study people in clinical research, meaning milder stages of cognition, and so forth, and different tests to use. So there are a lot of debates as to what makes the best study that will give us the answer about cognitive medicines. With that said, there is quite a bit of research ongoing looking at medicines for their treatment in cognition and Parkinson's at stages of mild cognitive impairment, as well as dementia. In addition, there are some studies underway looking at neuromodulatory techniques or deep brain stimulation to stimulate areas of the brain that we think are involved in memory and thinking. There's also a great and growing interest in non-pharmacologic therapies for cognitive changes in Parkinson's. And those include physical exercise, cognitive training, mindfulness, and other activities. Some of these studies show promise for physical exercise, improving scores on cognitive tests after many weeks to months, as well as there may be a role for a cognitive training in helping someone develop a certain skill or a certain area to improve, say, their attention or memory on certain tasks, as well as to develop compensatory strategies for dealing when cognitive changes are present. These can include, as far as compensatory strategies, things like keeping a list or putting labels on items, writing things down, having pill reminders, and many more. These are some of the strategies actually that other team members may play a key role in. So people with Parkinson's experiencing cognitive changes may also work with speech language pathologists and occupational therapists to help with their cognition and develop day-to-day strategies. In closing, I hope you've learned more about cognitive changes that may occur in Parkinson's, but again, that may not affect everyone. Managing cognitive changes in Parkinson's really does take a team approach. So not only the physicians, neurologists, movement disorder specialists like myself, but the whole team of rehabilitation therapists, social workers, nurses, psychology, neuropsychology, and so many more. We can all play a role, and we are here to help. Thank you.
All right, welcome back. And now we'll get ready for some questions for Dr. Goldman, who will be joining me. There she is. Thank you, Dr. Goldman, for your time this afternoon. We've gotten some questions from the audience, so we'll just jump right in. All right. You talked about a lot of the cognitive changes. How do you know if a cognitive problem is caused by Parkinson's or is a symptom of dementia or Alzheimer's?
Thank you, and thank you for all these great questions and your attention for this program. So cognitive problems, as we talked about in this session, can be seen in Parkinson's, although I did mention not every person will be affected by symptoms in the same way. One of the ways that we can help distinguish whether a cognitive issue is related to Parkinson's or a different type of condition or dementia syndrome like Alzheimer's is looking at the profile of the cognitive changes and the timing of the symptoms, such that in someone with Alzheimer's, it's much more typical that their first symptoms relate to thinking and memory in particular, with very specific types of memory affected. And they don't have many of those other symptoms that fall in the motor category that we see in Parkinson's. We can also use neuropsychological testing to help pinpoint these profiles. In some, we can also look at different types of biomarkers or scans, like some MRI scans may give us clues, or cerebrospinal fluid markers may give us clues or different signatures. And we can also use that to help determine whether there's presence of cerebrovascular disease, which can contribute to dementia as well.
Okay, thank you. So is there any way during your early years of Parkinson's to know if you will experience cognitive changes?
Oh, that's such a great question. And that is a very active area of research to see how can we identify people who might be at risk. And then next step, obviously, what could we do about it to halt that progression or stop it in its tracks? So there are some things or clues that we know from research that may help pinpoint whether someone's at risk for cognitive decline. And those include a variety of different areas. So one of which could be certain genetic types or subtypes of Parkinson's that we've found for people who may have GBA mutations, something called glucocerebrosidase, may have a higher rate of cognitive and neuropsychiatric symptoms. Again, not everyone, but something we've seen in the literature. We can look to see, are there other risk factors related to history of prior head trauma, for example, or strokes or other conditions. And we're trying to understand whether there are certain different clinical subtypes of Parkinson's that might put people at higher risks as well, with some suggestion, and again, not entirely, so take that for all of that when we put all this information together, that people who have more of a balance and walking trouble with Parkinson's rather than a tremor predominant clinical picture, or someone who may have greater mood disorders or cognitive changes at their baseline diagnosis may be at higher risk. But again, these come from large, studies looking at populations, so we always need to think about what that means for an individual person themselves.
So it sounds like sharing your whole medical history with your provider is essential.
It's very important.
Good. A question, you touched on this about executive functioning. How do you have strategies to help with that, or organizations staying on tasks, or do you have a recommendation for another clinical care team member that may be better to assess that?
Oh, that's a terrific question. And executive function is a really broad area unto itself in cognition. And it includes not only staying organized, staying on task, doing more than one thing at a time, something we call dual tasking or multitasking. It can also involve mental flexibility and shifting from one topic to another, one thing to another. And so some strategies for dealing with executive function challenges are to take some tasks and really try to break them down into smaller increments to have them in manageable or bite-sized chunks, to keep lists, to work on various organizational strategies. And there's a whole host out there that are pen and paper, that are computer and app-based, and lots of opportunities there. And something that we work regularly with not only the person with Parkinson's, but also their family members to help with this organizational system. It's also important to take time when shifting from one task to another and kind of resettle into that framework. We quite often work hand in hand with our team members in speech language pathology and occupational therapy for some great executive function management strategies. But also our physical therapists work on dual task, things walking and talking and doing cognitive tasks in physical therapy or even exercise classes. So it's something we all can actually play a role in.
So definitely a team approach, and multiple people are going to be noticing or seeing things to make sure the other team or the patient with Parkinson's and their family are noticing these as well.
Absolutely.
On that note, what if you are that spouse or partner or family member who's noticing these things? What is your suggestion on, connecting with that person with Parkinson's, or, how can you help if it's starting to be concerning about, the safety aspect as well?
Yeah, thank you for that question. And it can be really hard to bring up some of these topics, particularly when one might see things that might be changing in someone, and there may be differences in the relationship or those dynamics. It's important to try to bring these up as best as possible, or in a very non-confrontational and non-judgmental way, and just even start that conversation of I've noticed some things, and trying to understand them, and I lend help or get appropriate medical attention to them. I think it can be important to help normalize some of these symptoms and experiences that people have, whether they're with Parkinson's or other conditions or aging. We all do change as we get older, and there are new things that come along, and trying to navigate that journey and put them in that context and approach them in a non-threatening and normalizing kind of way.
That's a great lead into another question we received from our registration about a person sharing that their father is living with Parkinson's, and they've moved him where he was getting physical therapy now to an apartment in a different part of town. Exact same floor, layout, furniture, everything is the same, but doesn't feel like his. It's not actually his. So how do you help with any of those hallucinations or delusions that you may be seeing? Can you comment on this? Any helpful strategies?
Sure, yeah, thank you. Really appreciate this question, because it touches on a topic that can be interrelated with cognitive changes in Parkinson's. Again, not everyone being affected with some of these neuropsychiatric symptoms, but having confusion about one's environment, or delusions, fixed or false beliefs that something isn't exactly what it seems, or someone says it to be, can occur and can be very unsettling, not only for the person with Parkinson's, but their care partner or family member. And I think there are a couple of things that are important to note there. And one is that changes in environment can take some time to adapt to, whether that's moving to a new place, going into the hospital, or being even switched from one hospital room to another. That disrupts someone's sense of their environment, their sense of space, what's familiar or not familiar. So trying his best to orient someone to the surroundings, give them time to adapt to those new surroundings, in showing things that are familiar to them, and explaining why they're there and what they are in the environment can help familiarize that scope. If there are hallucinations, which can be things like seeing things or hearing things or misperceiving things that aren't really there in the environment, or delusions, there can be other strategies, including different types of medications that might be necessary to look at. Again, reorienting strategies, reassurance, and just recognition of what someone's seeing in that moment is their reality, but may not really be what is going on, and to try to work through that.
That is a tough one, especially during COVID times, as things have shifted on how we do and get in and out of doctor's offices as well. But hopefully there's more virtual opportunities. All right, switching topics to a little bit about the nutrition pieces, or the chemicals, as you mentioned, that may affect cognition. Are there any blood tests to see if you're deficient in nutrients that may be affecting this cognitive or executive function?
So one of the things that we look at too, particularly from a medical perspective, is when someone's experiencing changes in their cognition, is there something else that could be this could be attributed to from a medical standpoint? And sometimes those can involve various medical illnesses, conditions affecting one's thyroid, or in the case here of vitamins, looking at vitamins such as B12 and folate. We know that low B12 can be associated with cognitive changes and mood changes like depression, and can be treatable. Oftentimes, if we actually do find a low level, working with someone's primary care physician or internist, the next step is to find out why someone has a low level. And that could be due to a number of either medical conditions or certain types of diet, like a vegan type of diet where one's not necessarily getting the same nutrients. And some of these could be looked at through regular blood work and working with one's primary care physician as well.
Great, thank you. All right, just give me one moment here. We've had a flood of questions coming in. Speaking on back to the cognitive decline and not knowing, when that would happen in your journey, is there anything a person with Parkinson's can do to minimize the chances of cognitive decline?
Sure, that's another great question. And this flood is really testing Erin's multitasking executive function skills behind the scenes. Terrific. And so I think, we want to be as proactive as possible and as best as we can. And so I think there are a couple emerging themes that we find interesting in helping one's cognitive skills and abilities as people age. And actually, one of those benefits may be from physical exercise. So more and more as we learn about exercise, not only are there tangible motor benefits, but also benefits for mood and sleep symptoms, but potentially also cognitive symptoms. And this, again, one of those very active areas of research study. I think in addition, what we've learned from other studies of aging or from Alzheimer's studies and that literature is being active mentally. So continuing hobbies, reading, work, ways that we keep our brain active and engaged. Another thing that we've learned from that literature too is also keeping up one's social network and that social environment. And I think we all recognize how difficult that's been, especially this past year with COVID, and the chances of increased isolation. But maintaining that social network or discussion and engaging conversation, even virtually or over the phone, keeps one's brain active. And then, of course, trying to minimize other medical comorbidities that can affect cognitive function. And those have to do with keeping good control over one's blood pressure. So treating hypertension, treating diabetes and cholesterol issues if present, and also treating mood disorders too. So a lot of things that one can aim to be as best proactive.
You must have read my mind because mood disorders was my next question. Thinking about anxiety and depression that you've been treated for and with your Parkinson's. Can you comment on how to treat these mood symptoms, especially now with pandemic times as we're starting to slowly get back into connecting and being social again?
Sure. And I know, the focus today was cognition, but it really highlights how so many of these non-motor and so many of these neuropsychiatric symptoms go hand in hand or indirectly or even directly related to one another. So sometimes what we do for one thing affects another and vice versa. I think we've also learned that depression and anxiety can be common in Parkinson's throughout its course and at different times. And again, this doesn't affect everyone with Parkinson's, but it's something that we can see even before someone has a motor diagnosis, as someone adjusts to having a new diagnosis or changes in their functions. And I think it's important to know that depression and anxiety can be treatable and managed through a variety of different strategies, including counseling and cognitive behavioral therapy, as well as medication. So there are many medicines that work through various neurochemicals that are used for depression and anxiety. We work hand in hand with many of our team colleagues on this, whether from a movement disorder neurology standpoint, primary care, geriatrics, psychology, psychiatry, social worker, and our nursing staff. But it's important because I think sometimes when those symptoms go hand in hand, treating one's anxiety can help one's attention and ability to not be focused so much on that anxiety, but actually think about what's on the cognitive realm. And similarly, treating depression can help. Sometimes the antidepressants can be a little bit activating and elevating in that sense too.
Thank you. You mentioned the 5 domains of the cognitive functioning and thinking about that language piece. Is it common or something that you see in people with Parkinson's that they're mixing up their words or saying words that were not intended or writing words that were not intended?
So language, again, we try to, at least on our end, group things together to make sense of them. And we know sometimes we put things in boxes that are a little bit artificial, but help us from both clinical and research standpoints. And so language, there's actually quite a bit that goes into language in terms of comprehension, reading, writing, spoken language, and so forth. So kind of putting a lot into the language bucket. But probably what we most typically hear in Parkinson's is that people may have challenges in finding the right words that they want to say. So it's sort of like it's there, it's on the tip of their tongue, but it's just not quite coming out, or it's slowed to get from the brain out through the mouth and to be said. And there are ways that we look at that. We call that verbal fluency. And sometimes we look at that for different categories or different letters or just in conversation. People's sentences can also be a little bit reduced. So instead of probably the way I'm talking right now in long-winded sentences, they may be shorter, more truncated in the content in each sentence. Some of those other word finding changes or word substitutions or misusing the words, calling something by a different name may or may not be as typical of Parkinson's, and I think maybe something that we look at through more detailed testing of language and neuropsychological tests, and potentially even brain scans as we look to see what areas of the brain are involved in language. So it can be a complicated area, and to understand exactly what symptoms are and what they might relate to.
Okay, great. I received a couple questions regarding sleep. As you mentioned, having sleep difficulty may have an impact on your cognition. Could you comment on that and even discuss the REM, sleep behavior disorder, and if that has any outcomes in terms of cognition?
Sure, yes, and sleep, there's some fundamental things that we all do. Sleep is one of them, thinking is one of them, moving is one of them, and nutrition we touched about. So I think these are really core, great topics. And we do know that sleep can be affected in Parkinson's in many different ways, from trouble with nighttime sleep, with something called REM, sleep behavior disorder, that you just mentioned, which is otherwise known as dream enactment, or when we're dreaming and in REM sleep, we're supposed to be still and not moving around, but there's a loss of that muscle tone in Parkinson's where people may talk, yell, kick, or act out their dreams. Sleep can be changed in Parkinson's with insomnia or fragmentation, or even, Parkinson's symptoms like stiffness or tremor that may make it challenging to turn over or get out of bed. And of course, people may need to get up to use the bathroom at night. And then there can be some daytime changes with increased sleepiness during the day. And I'll touch upon that in a moment. So sleep goes hand in hand with cognition. And I'm pretty sure all of us would recognize a time that we didn't sleep well and we didn't think our thinking was at its best the next day. So there's an importance for trying to get as best a good night's sleep as possible. So REM sleep behavior disorder is a really interesting phenomenon related to Parkinson's. And what we've learned now is that it can precede the onset of Parkinson motor symptoms by years, even decades, and has been one of those prodromal or premotor clues, perhaps to help us identify who might go on to develop Parkinson's. There's a lot of research in that area. We've also found that in REM sleep behavior disorder, when people have been followed over many years or even decades, they could develop not only Parkinson's, but other disorders called synucleinopathies, which share a certain protein that aggregates called alpha-synuclein. And that can be present in Lewy body disorders like dementia with Lewy bodies. And some studies have suggested there's a link to cognitive changes as well. So I know one topic that came up along the sleep lines was the role of too much sleepiness during the day. And there can be a number of reasons for that, including not sleeping well at night. Sometimes medicines can make people drowsy or sleepy during the day, whether those are Parkinson's medicines or non-Parkinson's medicines, certainly. Or even, if someone's depressed or having apathy and there's just not much they want to do during the day. We have found that for some people, some of the dopamine medicines can be linked to daytime sleepiness. For some medicines, such as the dopamine agonists, fall into one of those categories. Although we do recognize for some people, levodopa can be associated with sleepiness. And so I think it's always important to try to sort that out. We often work with sleep colleagues, so sometimes it's needed to do an overnight sleep study to understand what is going on, or to diagnose sleep apnea, which is something that's also treatable, generally with CPAP or similar machines. And so I think we need to balance that. So going back to that organizing one's day, having activities, that's one really good way to look at someone's day and plan it out and say, okay, what is today's activity, and have that on a calendar and prepare and keep that regular schedule. But also to allow for a little downtime if someone needs, and maybe sometimes people need a short nap, although what we don't want to happen is that people sleep so much during the day that they don't sleep at night, and then they're, vicious cycle on that front. So lots of information in that answer there.
Yes, that was great. That was great. All right, we're on to our last question. We have just a few minutes left. I heard you mention research on the sleep, but is there any research on cognition and Parkinson's that you can share about?
Sure, there's lots of research going on in cognition and other symptoms in Parkinson's. And I will say, having been in this field for a number of years, it's really amazing to see the trajectory and interest in research of all kinds into these non-motor and neuropsychiatric issues, including cognition and dementia. And so that's really, really important. It takes a village for all of us to come up with new strategies and new therapies. So on our clinician research end, and whether it's pharmaceutical companies, government agencies, and people taking part in these studies, like people with Parkinson's and their care partners. So there's some studies, and again, there are always some resources out there looking at clinicaltrials.gov as one example to find research studies near you. But some of these are looking at different types of medications for cognitive changes at various stages. Some are looking at cognitive rehabilitation strategies. There's been some work being done looking at transcranial magnetic stimulation or neuromodulation, and other techniques and biomarkers to understand what's really going on in the brain and body with these changes. We're actually doing a current survey funded by the Parkinson's Foundation that was actually led as a team approach with healthcare professionals, teamed up with people with Parkinson's and care partners to create a survey to understand really what should we be doing in the field, what are the needs and priorities for clinical care and research and education and support regarding neuropsychiatric symptoms, and to really gain input from a wide representation of people actually living with Parkinson's and their care partners to help inform this. So there's lots of research out there.
Great, and we just shared the survey link and the flyer link in our chat, and I will also make sure to include that in our follow-up email to today's attendees. So that was wonderful. Just to note, I know we had so many questions coming in, and some of them were about medications. And so I just want to share that we have a Parkinson's 101 coming up, what you and your family should know, on Wednesday, April 21st. So I put that link in the chat. This is where you can go to find that kind of Parkinson's 101, Parkinson's basics information that Dr. Goldman was not able to address today, as our topic was focusing on cognition. So thank you so much, Dr. Goldman, for your time today and great presentation. And with that, I just have a few closing slides to share. So thank you again to Dr. Goldman, and thanks to our attendees today on Zoom. We'd also like to thank our program sponsor, Light of Day, for this support. Today's session has been recorded and will be available for viewing at our Parkinson's Foundation YouTube channel. As our program concludes, a window will pop up so you can complete an evaluation on today's program. We so appreciate your feedback as we use this information for planning future programs. You will also receive an email with the link for today's recording in the coming days with resources and that link to Dr. Goldman's research. In addition to the Cognition Talk series, we are hosting virtual events each Monday, Wednesday, and Friday of the week. To learn more, check out parkinson.org/pdhealth. So we have PD 101 coming up April 21st. But we'd love for you to join us next week for social engagement brain games. Not just fun and games, studies suggest there are many cognitive benefits for people with Parkinson's who participate in puzzles, trivia, and brain teasers. Boost your wits and your mood by joining with peers and exercising your brain. So hope to see you next week. And again, I'm sorry we weren't able to address all of our questions today. So please Feel free to reach out to our helpline at 1-800-4PD-INFO or email them at helpline@parkinson.org. You can use that same contact information to order free resources, educational book series, and our hospital safety kit. Again, thank you for joining us today, and know that you are not alone. You are here within our Parkinson's community. Thank you and enjoy the rest of your day.